Good afternoon, everybody. Today's topic is the microorganisms of the respiratory tract. Now, when I'm going to do the organisms of the respiratory tract, I'm going to have a couple of subheadings I'd like to follow in each case. First of all, I will talk a little bit about the anatomy of that system we're going to be talking about. We're going to talk a little bit about how we acquire these diseases. We talk a little bit about your defenses in these particular areas. You're not just going to sit there and take assault from organisms, so you are going to defend yourself. We're talking a little bit about symptoms, general and sometimes in specifics, and then we'll talk a little bit about some of the diseases. And that's the way I'm going to try to follow, the pattern I'm going to follow for all the different systems that we are going to be studying. So today we're studying the respiratory tract, organisms of the respiratory tract. And going according to my own way of doing it, we need to talk a little bit about the anatomy first. Now, our respiratory tract, if we're talking about the anatomy, is divided into two parts. We have the upper respiratory tract and the lower respiratory tract. Now, the upper respiratory tract, I list there all the parts: the mouth, the nose, the nasal cavity, the sinuses, the throat and the pharynx, and the epiglottis. And then the lower respiratory tract, when we talk about the lower respiratory tract, we're really referring to the trachea, the bronchi, the bronchioles, the lungs, and obviously the alveoli in the lungs. I have more of a diagrammatic representation here, taken directly from your book. And I would like you to know that every single one of those areas mentioned there, you could be, that every single one of those areas could be infected with different types of bacteria at different times. So, for example, you might have, for the sinuses, you end up with sinusitis, otitis media, the middle ear infection, rhinitis, the nose involved, the pneumonia, the lungs involved, epiglottitis, the epiglottis, pharyngitis, for the pharynx, the involvement of the pharynx and things like that. So we are going to try to limit as much as we can our discussion on some of the very important organisms causing infections, but there are many, many, many different organisms that could attack these areas, and we'll touch on a few of the important ones. So that's basically the anatomy. I am not going to go into any further details because this is not an A&P class, and your A&P instructor must have gone into greater details. I just want to focus a little bit, just to review a little bit so you know what we're focusing on. So how do we acquire these diseases? How are they acquired? Well, diseases of the respiratory tract invariably are acquired by inhaling something. Usually an individual has an infection, and one of the major symptoms of respiratory tract infections would be sneezing and coughing and things like that. And sometimes they create aerosols that can be in the air, little droplets with organisms in it in the air. And depending on the organism they're spewing out, some of them could be viable for hours, if not days. And so another individual, will be inhaling those organisms. And if your immune system is not strong enough to fight them, you can end up with the disease too. So that's how people generally acquire these diseases, by inhaling. We are not going to go into some of the unusual cases, like in a hospital setting. There's something we call aspiration pneumonia. You're not inhaling anything from the outside. but you are infecting yourself with your own organisms. We're not going to go into that. But in general, organisms of the respiratory tract, diseases of the respiratory tract, are acquired by inhalation of the infectious particles. So how are you defending yourself from these organisms that are trying to get into your system? Well, I list there some anatomical protection from the infection. And I think we talked about them already when we were doing first line of defense in another lecture. Nasal hair will trap particles. We have cilia that will propel particles or organisms upwards and out of the system. In the respiratory tree, especially in the trachea and the bronchi, there is something called the cilia escalator. And that's what I'm talking about. They are going to move organisms upwards and try to get them back out. Of course, we have mucus, which is a natural trap for invading microorganisms. And once they're trapped, they are there, they kind of trigger the cough and the sneeze reflex, and sometimes you swallow. They're all in an effort to move these organisms away from sensitive areas. Okay, so there is also, maybe I should mention that first before I come back to the second line of defense, because your normal flora is part of your first line of defense. And your normal flora, these are bacteria that are there. And I told you before, they are almost like the guards at every portal of entry. They're there, they're protecting you. They could be fungus, they could be some protozoa, other organisms, but most of the time they are bacteria. And their job is to suppress the pathogenic potential of organisms. And I said that because many species of bacteria that are really very highly pathogenic can be part of your normal flora. Neisseria meningitidis, Staph aureus, Streptococcus pyogenes. These are highly pathogenic organisms that could be very devastating. You can find a few of them among your normal flora. And as long as they're not taking over, suppressing the others and just take over and then proliferate on their own, it's okay. But if anything happens and they're triggered to just multiply out of control, they can be very devastating. But again, there are some highly pathogenic organisms among your normal flora. But as long as they are suppressed and they don't get out of proportion and they still remain within what, let's say, their limits, they're still going to be okay. Another thing I would like to mention about your normal flora is that they put up what they call that microbial antagonism. That's basically their function there. They are holding on to a spot in and on you. They don't want strangers to come in. And so they are going to put up a fight if other pathogens are coming in there and trying to take hold of their little territory, their little niche. So that antagonistic response is going to be there. Note that the normal flora might be different in composition depending on the individual. A normal, healthy individual may have a different normal flora composition than a person who is a smoker or maybe a person who has COPD or some underlying lung disease or something like that. So the normal flora is not exactly the same in every individual. It might shift a little bit. So please note that. So that is your first line of defense. We talked a little bit about the nasal hair, the mucus that trap the organism, the mucus, the ciliary escalator, the reflexes of coughing, sneezing, swallowing, things like that. Those are all your first line of defense. But there is also a second line of defense. And many times your second line will include things like complement. The complement will be triggered or activated, antimicrobial peptides. We talked a little bit about cytokines and the macrophages coming into play, secretory IgA, when we talk about the different types of immunoglobulins, the antibodies. I mentioned one of the jobs of the IgA antibodies, protection of the mucous membranes around the system. And so these are all things that are working in your favor against the microorganisms. Okay, so that's your defense. And of course, we talk when we get into the individual diseases themselves, we'll talk about a little bit about some third line of defense where you will be producing antibodies against specific organisms, your third line of defense. All right. So we did, I think, the anatomy, how you acquire your defenses, some symptoms, maybe some general symptoms of respiratory diseases, initial symptoms, the runny, stuffy nose, the coughing, the sneezing. And when I say coughing and sneezing initially, that's because of the organisms being trapped in the mucus that will trigger the coughing and the sneezing reflex. It's not like they have caused you damage yet and you have the disease. Later on, if the lungs are involved, then there is another, what I call secondary coughing, which is basically what's going on. You're really coughing because you want to clear up the passages. The tubules are so filled up with gunk that the air is not getting through. And one of the reasons for coughing is to try to unclog some of those passageways so you can breathe a little easier. And then, of course, you're going to have the difficulty breathing. Once the lungs are involved, you end up with difficulty breathing, the fever, the chest pain. Cyanosis usually step in because if you're not breathing properly, that means you're not having the proper amount of oxygen exchange, and you started to get bluish in color, and they refer to that as cyanosis. So these are some of the general features of respiratory diseases. Now, what I want to do is talk in some details about some specific diseases. Maybe I'll talk about two of them, and then I'll let you do the rest of them following the same pattern, because it will be very difficult to go through each one of them and still, for me, to give you a decent lecture within the period of time and still keep it within the time. So you are going to follow the same way I'm going to be doing it and try to do some of the diseases on your own. Obviously, if you're having any questions at all, I'll be available to answer them. So one of the diseases I would like to focus on is pharyngitis, inflammation in the pharynx. And of course, I have some signs and symptoms there: the pain, inflammation of the throat, reddening, swollen mucosa, swollen tonsils, generally a foul smelling breath. And you can have white packets. Your book has some beautiful pictures. You can look at them. where you can see some white packets on the walls of the throat and further down in the tonsillar area. You can see that especially in streptococcal disease. Now, pharyngitis is more like an anatomical diagnosis, meaning there are many different organisms that could cause inflammation in the pharynx. You can have some viruses. In fact, the same viruses causing the common cold. You could have mechanical irritation from prolonged shouting or drainage from the sinus cavity. But the most serious infection that I'm going to be talking about is the strep pharyngitis. So I'm going to focus on the streptococcus pharyngitis. And I made a note there that usually the sore throat caused by bacteria are generally more painful than those caused by viruses. And usually they are accompanied by fever and headache and nausea and things like that. But like I said, I am going to just focus on the strep pharyngitis. But I want you to keep in mind that many different organisms could be causing pharyngitis. Now, when I talk about strep pharyngitis, I'm talking about an organism called Streptococcus pyogenes. Okay? Now, Streptococcus pyogenes is a gram-positive coccus, and it's a streptococcus. You know by now that they grow in chains. That's why we call them streptococcus. They do not form spores. They're generally non-motile. They don't form capsules a lot. And they're generally aerobic organisms, but they could be facultative anaerobe, fermenting a variety of sugars. Streptococcus, the whole genus strep to begin with, they do not produce all those species of streptococcus. None of them would produce catalase. Strep pyogenes that we're going to be talking about is a beta hemolytic organism. Okay? Now, this organism, if we're talking a little bit about the pathogenesis of this organism, we'll learn that if left untreated, streptococcus can result in some very serious complications like scarlet fever and rheumatic fever and glomerulonephritis. So what about this organism that is causing or that can cause so much damage? The mere fact that this organism can cause so much damage is telling you that it does have some very powerful weapons against you. Because remember, your immune system is really a very powerful weapon there too. And if these organisms can cause so much damage, then obviously they are going to be producing some kind of damage. They must have some very powerful weapons. So let's see if we can talk a little bit about the weapons that these organisms are producing. A few of the weapons are listed here. Now, we call them the virulence factors. Specialized polysaccharides on the surface of the cell wall of these organisms prevent the organism from being dissolved by lysosomes. That's good for the organism, very bad for you. Another thing I should mention that they're lipoteichoic acid that contributes to the adherence of this organism to cell. And if they can adhere to cell when you are coughing and sneezing and trying to swallow, they are adhering very strongly and they're not going to let go. There are also some M proteins that cause the surface to be a little spiky. And the spikes will deter phagocytosis. Again, good for the organism, bad for you. Now, some of the organisms produce certain proteins we call streptolysins, and their job is to hemolyze red cells. Okay? Now, these streptolysins can injure many cells, not just red cells. They can injure cells and tissue, like leukocytes, the liver and the heart muscles, and so on. But when we talk about the streptolysin diagnosis in the lab, we'll realize that these organisms will really destroy your red cells on agar media, and we notice that they're going to be beta hemolytic organisms. They also have that erythrogenic toxin. We'll talk a little bit about the scarlet fever. They talk about it produces the erythrogenic toxin that will give that reddish. They're responsible for that bright red rash that's very typical of that disease. All right, so those are some of the virulence factor of this organism that make them so much more dangerous than your normal flora will be able to, or you will be able to protect yourself from them. Now, pathogenesis, when we talk a little bit about the pathogenesis, that's what we're talking about, all the damage that they could be doing to you. Now, how do we diagnose such a disease? Let's say you have pharyngitis. How do we diagnose such a disease before even going to how do we prevent them? Ordinarily, if you have a strep throat, for example, you can have the doctor sending a swab to the lab, and the lab will do a couple of different tests. Well, one of the tests that the lab will do is a rapid diagnostic test. They are available. They're not 100% accurate, but they will give the doctor enough information to at least say, okay, looks like it's going to be strep pharyngitis, let's treat. Of course, the lab is also going to be doing some cultivation of the organism and trying to identify it that way. That takes a little bit longer because organisms got to grow. One of the things that we do in the lab as a diagnosis of this disease is, first of all, put it on a blood agar plate. We should see beta hemolysis, clear zones around the colonies that are growing. And if you do another identification test, more sensitive identification test, these organisms are generally sensitive to bacitracin because group A strep, group A, which is our strep pyogenes, that's one of the ways we will diagnose. It is sensitive to bacitracin. Now, there are many, many different serotypes of beta strep. Okay, and you may develop immunity to one serotype. There are about 80 of them. But the thing is that immunity is serospecific, meaning if you are immune to one serotype, then you're not immune to the others, and you may end up getting a series of different diseases throughout your lifetime, different pharyngitis due to the different serotypes of the organism. Then it's not like you can get the disease once, be treated for it, get cured, and don't get it again. There's so many serotypes, and immunity is serospecific. So how do we prevent ourselves from getting this disease? Well, obviously, we need to make sure that we take some precautions. And most of the time, the only way you can prevent it is good personal hygiene. It's very difficult if something is in the air and you happen to be in the area not to be inhaling it, but usually just hand washing, especially after you cough and you sneeze, and before you eat your food, especially if you're going to touch the food or if you're preparing food for somebody else. It's very, very important that you do your hand washing. I told you many times before, probably one of the most important things you can actually do for yourself and for everybody around you is hand washing. We don't have any vaccines available for pharyngitis, so you really have to do diligence and try to protect yourself from contracting the organism. Treatment. It's not very difficult to treat pharyngitis with Streptococcus pyogenes. Penicillin works very well. It is generally the antibiotic of choice. But remember, there is also penicillin allergies. And so we need to find other drugs that are going to be also effective against the organism. Antibiotic is definitely needed to prevent serious sequels. Remember what we talked about the disease itself. If left untreated, you can end up with scarlet fever, rheumatic fever, and glomerulonephritis. What's going on here? It just seems like you might end up with pharyngitis, and you may say to yourself, hey, it's just a sore throat, it's difficulty swallowing, I'm having a little pain here or there, whatever. I'm not going to go to the doctor, I'll be fine. But they are the sequel to the disease. And scarlet fever and rheumatic fever happen to be. Actually, glomerulonephritis too, dangerous sequel. It turns out that if you develop antibodies to the organism, which means the strep pyogenes organism, there seem to be some proteins on the strep organism that are so similar to the proteins of the heart muscle, is that when the antibodies are trying to fight the organism, they're also attacking your heart muscle, causing that rheumatic fever. And so you end up, with rheumatic fever. Another sequel, like I said, is scarlet fever, where you can have almost like an allergic reaction, where you start producing those erythrogenic toxins that will give you that cherry red discoloration. In fact, I say strawberry tongue there because if an individual has a strep throat and don't take care of it, eventually they'll end up with this red rash. And one of the ways to diagnose it, actually, doctors will tell you, and just about, mythical grandmother knows about it, where you just ask the patient to stretch out the tongue. And it does look like strawberry. I mean, those red tongue, it's really cherry red with those black blotches on them, like you'll see on a strawberry. And they actually call it strawberry tongue. And another sequel, like I said, some of those toxins that are produced will also damage not the red blood cells alone, but some other tissue cells, including tissue of the kidney. So you don't want to fool around with Streptococcus pyogenes. Take care of that. Get your antibiotics, take care of it, get it out of the way, and then you don't have to worry about the rest of them. All right. So and by the way, those antibodies we're talking about, that's where the third line of defense comes in. The other disease I would like to focus on is the tuberculosis. A lot of you might have heard of TB. Okay. And it is one of those diseases that is really very, very difficult to treat maybe easy to acquire, but very difficult to treat. So we will try to focus a little bit on TB caused by Mycobacterium tuberculosis. So what do we know of TB? Well, it's one of those diseases that has been around for a very, very long time. Mummies, your book talks about the mummies from the Stone Age, ancient Egypt and Peru, provided evidence that TB was what they refer to as the captain of the men of death. It's really still a worldwide threat even up to this day. There was a period of time with the advent of antibiotics like isoniazid and streptomycin. There was a little relief at one point, but this disease has reemerged as a very serious threat. Currently, you have 2 to 2.5 billion with the B people infected with Mycobacterium tuberculosis, and 1.3 million deaths, and that was in 2013. Now, it may sound like old statistics, but that's the delay that we have. That's how many deaths in 1 year. I don't know how many of you know of TB, but about 85% of TB is contained in the lungs. The other 15% is disseminated. You can have what they call extrapulmonary TB, which is really very common in immunocompromised patients. So you can have extrapulmonary TB, meaning away from the lungs, kidney TB, bone TB, brain TB, and a lot of times those are a little bit more devastating. And fatalities are very common in those cases, especially if the brain is involved. All right, so you have about 15% that's disseminated. But a lot of people, when they hear TB, they're thinking lung TB. So what's going on with this organism that is so very difficult to treat? It seems to be hanging around for long periods of time. Let's talk a little bit about the TB organism itself. It seems like the Mycobacterium tuberculosis would infect the lungs, which is fine. They have the weapons, they got into the lungs. Your response to it should be the macrophages will come and engulf them, and they do. But the thing is that these organisms, even though they were engulfed by the macrophage, they continue to grow in the macrophages. At this point, the patient is asymptomatic, but organisms are growing in the macrophages, and they keep on growing and growing. Many times the macrophages will just break open and they'll invade more. Eventually, they will end up in the bloodstream and the lymphatic. Now, your system, the immune system, will mount a complex cell-mediated assault against the organism. And you end up with an influx of mononuclear cells in the lungs. And what happens is there is something called a tubercle that's formed. So this tubercle, there is a central core containing the TB organism in this enlarged macrophage. And the outer wall is like fibroblasts, lymphocytes, and macrophages. So your immune system is trying to kind of limit the spread of the organism by producing this wall around the organism, around the infected macrophage. And this is what they call the tubercle. in an effort to contain the organism. Now, when you try to diagnose the TB, and generally doctors will go and request a chest x-ray, for example, you see this infiltration, many tubercles all over the place. Now, if they stay there and they're not going anywhere else, you say the disease is now contained, but it's not, because you have neutrophils that will release enzymes to break down the tubercle walls. And then they end up with exposing the contents. Eventually, what will happen, caseous lesions will develop, and your lung tissue is replaced by calcium deposits. So your immune system is trying to kind of localize the disease, put them in tubercles. Tubercles are there though. And there might be a two-edged sword, because if those tubercles break open, because if you keep on coughing and they break open, then they release the tubercle organisms to start the damage all over again. So it's very difficult. Okay, so you have to worry about the disease itself. Now, I failed to mention a couple of things about the organism. And I did mention that it is the Mycobacterium tuberculosis organism that's causing the disease. The organism itself has huge problems in the way it grows, in the way we can treat it, and so on and so forth. And when we get into culture and diagnosis later on, we'll probably talk a little bit about that. Now, if you're infected and the doctor starts treating, the majority of adequately treated patients would recover. Almost completely though, but not completely. Because some live bacteria can remain dormant and become reactivated later on, maybe weeks later, maybe months, maybe even years later. So your primary tuberculosis could be treated. You may almost recover, but there are going to be those few residual organisms that will cause problems later on. And it could be years later, causing this secondary TB. And the secondary TB is generally more severe. Violent coughing, extreme fatigue, weight loss, and you start to just waste away. The body is just wasting away. In fact, one of the old names for this disease was consumption. And that's because of this wasting away. In secondary TB, the mortality rate is almost like 60%. Okay. So it is a huge problem. And so we also have, like I told you, 15% disseminated TB there. Now, the causative agent, Mycobacterium tuberculosis, is an acid-fast positive bacteria that's aerobic, very slow growing. Now, I told you that our ordinary bacteria like E. coli and staph and whatever, they may have a generation time about 15, 20 minutes, even if it's a half an hour, some of the normal organisms we use in the lab. You can find a colony of bacteria growing the next day if we inoculate them on agar media. The acid-fast bacillus, the Mycobacterium tuberculosis organism, will take, the generation time is about 15 to 20 hours. It will take months for you to see a decent sized colony growing on agar media. And because it takes so long to grow, in, in previous years, not anymore, it used to be almost 6 months. It's not unusual to have this organism trying to diagnose, trying to identify the organism, 6 months growing in the lab. The Lowenstein-Jensen media will be, put in the incubator and you examine it once a week for months before you throw them out and say they're negative. And if something has to grow, even tiny, tiny colonies, you see, you got to let them grow a little bit more, and then you start doing biochemical tests to identify them. So it was very difficult. Nowadays, they do have some faster tests where we can do PCR testing. We're kind of making copies, millions and millions of copies, so we can identify the organism a lot faster. But it wasn't that long ago, a couple of decades ago, where some labs will take 6 months, if not more, to actually grow, identify, and try to figure out what it's sensitive to, do a sensitivity testing on it. We talked about the organism being acid-fast positive. We did acid-fast stain in the lab. And we mentioned that there's something called mycalic acid that will give it that waxy coat on the cell wall. That makes them resistant to drying and also resistant to disinfectants and things like that. But that's also the reason why when we're doing the stain, we actually steam the smear so that the dye will melt the waxy coat and penetrate into the organism. Now, I have there a couple of organisms there. Mycobacterium avium. I mentioned when we were doing the AFT stain in lab that there is something called the MAI complex, the avium intracellulare complex. And I put a little asterisk there, if you remember. That is because these organisms in a normal, healthy individual will not cause problems. But in the immunocompromised patients, like the AIDS patients, they will cause problems. And you still have to pay attention to them and treat them. There is something called Mycobacterium bovis, bovine, meaning from the cows. And you can find that organism generally in not pasteurized, unpasteurized milk. In fact, that's one of the reasons why milk is being pasteurized. It looks very much and can mimic Mycobacterium tuberculosis in a lot of ways. Not causing that severe a problem though, but when you're trying to cultivate the organism and try to identify it, it looks very, very similar. All right, so let's talk a little bit about the pathology. Well, we talked a little bit about the cell-mediated immunity, the survival of the organisms in the macrophages, and the formation of the tubercles. And that eventually, when the white cells, the neutrophils, are starting to dissolve those tubercular structures, you end up with calcification of the lungs because they are kind of replacing good lung tissue with calcified tissue. And of course, the secondary infections we talked about that are a lot more dangerous than the primary infections. Now let's talk a little bit about the epidemiology of tuberculosis. Seems like it's an infection of the poverty-stricken people, and they have limited access to medical care. They're generally not, they're probably limited access to food. And so they are not going to go for medical care. And so even if they have the disease, it's very difficult for them to contain the disease then. A lot of these people, they live in crowded surroundings. And so they can spread the disease very easily from one individual to the next. So some risk factors: inadequate nutrition, limited access to medical care, like I said, a depressed immune system, limited access to sunlight and fresh air. So we know that, people who work in nursing homes, or if you have people in nursing homes and hospitals or jails, they are really at a higher risk of contracting and having TB. So when we talk about that, about 60% of the cases in the United States are among the foreign born. They're coming in many times with the disease, or they might have had the disease. Remember what I said about secondary tuberculosis. They might have had the disease and maybe more properly treated, but remember, they're not completely treated. So it's possible that they get in the United States and then they end up with a reinfection, a resurgence of the disease years later. Culture and diagnosis. Well, culture, that's simple. We actually cultivate the organism on something called Lowenstein-Jensen medium. Remember what I said just now, that these organisms, it will take months to get a decent colony. So we need material, media that's not going to dry up very easily. So Lowenstein and Jensen came out with something that you could have them there for years and they will not really dry up. So organisms will have their time to grow on them. When we do a stain, here is a stain of the acid-fast stain. Remember, they're acid-fast positive rods, the red rods that you're seeing there. So that's another part of the identification, the clinical diagnosis process, culture and identification. And then, of course, we have some testing that can be done. There is a skin test. You call the Mantoux test. I think I have something there. And what they're doing, they're actually injecting PPD under the skin. And 48 to 72 hours, they're looking for the induration. I don't know if you remember, we talked a little bit about delayed type hypersensitivity. We're not getting a reaction the same time. It's not immediate. It's hours, days later. And that's what we call it. That's why we call it delayed type hypersensitivity. And what they're injecting there is something called PPD, purified protein derivative. And that is the basis behind the Mantoux test. Now, there's some other testing that they have these days. They're probably more rapid tests that they have. But this has been a traditional test, and it's still being performed by a lot of clinical settings. All right, so that's one of the tests that they do. Sometimes you can do a blood test, the interferon gamma release assay test. You do that from blood. What's going on there is that in the blood, you're looking for T cell activity because T cells are very much involved. Remember, we talk about delayed type hypersensitivity that is caused by a type of T cells. So the IGRA test, it's a blood test, and they're actually looking for T cell activity. You're not going to find that test very often, but it's one of the tests, a brand new test that's coming out in the market these days. People are not doing, well, they're starting to do it, but it's not like one of those tests that everybody's doing these days, but the Mantoux test they try to do. And of course, to identify, you do the culture and sensitivity. So that's how we diagnose the disease. I already mentioned about the x-rays and looking for those infiltrates. How do we prevent TB? Well, we get TB by inhaling the organism. So I guess we can prevent TB by limiting our exposure to those infectious airborne particles. Patients are generally put in isolation when they have TB. Nowadays, we do have what we call universal precaution. That is true. But even then, patients, when doctors really feel that the patients are going to spew out a lot of these organisms, they put them in rooms, usually individual rooms, with negative pressure, meaning there is always going to be a flow of air out of the room through, of course, filters. You're not going to just, like an air conditioner, reverse the airflow into the atmosphere on the outside of the house and not the inside. So what they do similar something, but the air is filtered before it gets out. So it's that negative pressure. So when you're treating your patient, instead of the organism coming towards you because they're breathing it out or coughing it out, it's being pulled away because of that negative pressure. A lot of people talk about the BCG vaccine. The BCG vaccine, I'm not quite sure if it helps too much, but there is what they call the bacillus. Two French men developed this vaccine, and they're injecting individual with what they call bacillus of Calmette and Guerin. And they are that extract they use, they vaccinate these individuals. And when you vaccinate these individuals, obviously they're going to respond positively to that tuberculin test, the PPD test we talked about earlier. So when you give the individuals vaccine, expect them to have a positive PPD test. It's not used in the United States, but it has been used elsewhere. And like I said, the results of this vaccination, they're really mixed. We still have an awful lot of people coming down with the disease. Now, the treatment for tuberculosis, it is very difficult, without saying it is very difficult to treat TB. Active TB is usually treated in two phases. Phase one, you use something called rifampin, INH, isoniazid, we call that INH, ethambutol, and pyrazinamide. Those four you use for about 2 months. And then you follow that with rifampin and INH, the isoniazid, for 4 to 7 months. That's your active TB. And sometimes that doesn't help. That doesn't work too well. You might end up with another round of it. Latent TB, the second phase, you end up with rifampin and rifapentine for 4 and 3 months respectively, and then isoniazid, the INH, for another 9 months. And again, like I said, many patients, if you feel as if you're completely treating them, but you have those few organisms that are generally left behind. But even when you try to treat patients, one of the biggest problems with TB treatment is non-compliance. What does that mean? Well, you can be monitoring. Look at the time period. It's not the doctor giving you um, penicillin, take 3 times a day for 10 days and you're done. We're talking months. And if it's a second round, probably years before you can finally say you're treating this patient. You cannot monitor these patients all the time. And so one of the biggest problems is non-compliance, meaning they are not taking their medication the way they should, the times they should, the amounts they should. So non-compliance is the failure to adhere to that regimen. And what comes out of that because of this non-compliance is the biggest problem, which is MDR TB, multiple drug resistant TB. Now, all the drugs you have in the market, if TB is going to be resistant to them, obviously you can't treat that TB. So what happens? That's the one that's going to be spreading in the community. Very difficult. And that is one of the biggest problems around the world these days, the multiple drug resistant TB. Pharmaceutical companies are constantly working feverishly to get more drugs out in the market, but it's very difficult to keep up with what's going on out there. So TB happens to be a very stubborn, extremely difficult to treat if you can completely treat TB. Some people will say you can never completely treat TB because it might pop up years and years later. So best thing, avoid it. You just try as much as you can to avoid it. All right. So that's my little spiel on TB. So I did the pharyngitis and the TB, and I will give you a little homework later on. But before I do that, I want to talk a little bit about, since we're doing respiratory tract infections, a little bit about pneumonia. Now, pneumonia, I wouldn't say it's a particular disease. It is an anatomical diagnosis. Pneumonitis is just inflammatory condition of the lung tissue, the lungs, the alveoli filled with fluids. And it's a very general name, could be caused by so many different organisms. So it's not like a particular disease, but an anatomical diagnosis of the disease, where we're going to have all the symptoms we talked about earlier, the coughing and the sneezing and the difficulty breathing and the wheezing and chest pain and the fever and whatnot. All those still will be the general symptoms of pneumonia. But I wanted to say a little something in general, because pneumonia has been one of the huge problems in communities, in the hospital setting. And it's something that I feel I should mention a little bit more about instead of just introducing it. More children die of pneumonia than any other infectious disease. In the US alone, 2 to 3 million cases, with about 45,000 deaths per year. So it's not anything to sneeze about. Now, the reason why I really wanted to talk a little bit about the general is because I want to talk about two types of pneumonia, or two categories of pneumonia, I should say. One of them is community acquired, and then the other one is health associated pneumonia, like nosocomial pneumonia. The the community acquired pneumonia, I'm sorry, those are the ones you will get from the general public. In your community, somebody has pneumonia, and you end up with the organism itself. All right. So that's the pneumonia, I want to kind of focus on. Like I said, variety of different organisms will cause these community-acquired pneumonia. But Streptococcus pneumoniae, which is an alpha hemolytic strep, causes about 40% of the pneumonia. They call it lobar pneumonia that you find. When I say community acquired, it's like in your community, maybe you're traveling in the subway. I don't mean your local area, your neighborhood where you're working or where you're living. You get that in places that you visit often enough. Streptococcus pneumoniae, it is a gram-positive, what we call diplococci. You're not quite, even though it's streptococcus, you generally find them in pairs a lot of times, short chains, but a lot of times in pairs. And the risk, there's some risk factors: old age, maybe the season, summer as opposed to winter, underlying respiratory diseases, things like diabetes, alcoholics, drug abusers. They're the ones that are more prone to having these diseases. And because of that, the older individuals especially, they're encouraged to take some of the pneumococcal vaccines they have around these days. Right? And the other organism I would like to say a word or two about is Legionella pneumophila. It's a little less common, but it's one of those organisms that you probably hear about. It's widely distributed in tap water, cooling towers, spas and ponds and things like that. In fact, now and again, you'll have mini outbreaks right here in New York. And a lot of times it's the water from the air conditioning that contaminates the air in the homes, or sometimes the water towers are contaminated, and so the water coming down to the building itself is contaminated, and the people in the building will get that. We mentioned a little bit about Histoplasma capsulatum, which is a dimorphic fungus that could cause disease. Usually you can have spores in the soils and whatnot. And so individuals can end up with this fungal disease causing pneumonia. Okay. The other thing I would like to talk about is the health-associated pneumonia, or what we call the nosocomial pneumonia. About 1% of hospitalized or institutionalized patients experience this type of pneumonia. Usually it's associated with mechanical ventilation, maybe the endotracheal tube, okay, the ventilators. In fact, in the hospital setting, they refer to them as ventilator-associated pneumonia, the VAPs. And anything, I should say, that's acquired in a hospital setting, you got to pay extra attention because they're a little bit more dangerous. Why? Because in a hospital setting, there are patients there with so many different types of diseases and so many different resistant organisms that many times, if an individual acquires, and these are hospital-acquired infections, when the individual acquires these infections, the infections are generally due to those very highly resistant organisms. They're difficult to treat. And look at that, the mortality rate could be up to 50% in many cases. Okay, so it's very important that when a patient is in the hospital, you take extra precautions to make sure that they don't develop this type of pneumonia, especially when they're on a ventilator. You really have to take care of those ventilators and help these patients out. Most frequent causes of these types of pneumonia, there is the culprit Pseudomonas aeruginosa. Acinetobacter baumannii, strep pneumonia is there, Klebsiella pneumonia, Staph aureus, and a lot of them caused by the methicillin-resistant staph, the MRSA, again, resistant species. And many times, patients will have pneumonia not due to just one organism, but multiple organisms, what they call polymicrobial pneumonia, many different organisms causing that pneumonia. How do we diagnose these types of pneumonia? Well, most of the time, doctors might want to diagnose using some material from the endotracheal tube, maybe bronchial lavage. They wash the bronchioles and send the wash to the lab for some information, culture and sensitivity. Not easy to get that specimen, but sputum, tracheal swabs, not very, very useful because of the intubation itself. Now the treatment, obviously antibiotics. A lot of people are already on antibiotic treatment, but to alleviate some of the symptoms of the disease and to make sure that the patient are not reinfecting themselves, what they call aspiration pneumonia, they claim that you should elevate the patient's head to about 45-degree angle. And proper care of these ventilators and respiratory equipment becomes very important. Okay, and of course, don't hesitate. As soon as the infection is suspected, you should start treatment right away and try to take care of what's going on with these patients. All right, so I think that's basically what I have to say about respiratory tract infections. And I'm going to ask you to do something, what I call, and I'll do that for every single one of the systems, the self-study. Follow the outline that I gave you or the way I presented the strep pharyngitis and the TB disease and see if you can talk a little bit about influenza, whooping cough, and diphtheria. They're all laid out in your book for you, but I want you to extract what you see in the book and put it in that format. Okay? And I will try to answer any questions you have, either in lab or during our activity hour. Okay, so please don't hesitate to do those. I am going to try to stop my recording now and we'll talk again for the next lecture.